This was a passenger, an 11-year-old passenger in a motor vehicle collision. The CT scan shows a relatively small collection over the left parietal region that has a lentiform shape to it, and there is associated some subarachnoid hemorrhage. But it looks like a relatively small area of injury. We want to look at the bone windows to see whether there is a fracture, and indeed, one can see that the inner table of the calvarium is fractured in this individual. So this was the Coup side of the injury, and the patient has a small epidural collection associated with it, likely from a small tear of a middle meningeal peripheral branch. Just to be sure, we would look at the thin section images. These are the 1 millimeter thick sections. The disadvantage of looking at the thin section images is that they do get more noisy since it is a 1 millimeter thick section. Nonetheless, although we can see some of the subarachnoid hemorrhage, we are still seeing a relatively small extraaxial collection here. We can measure this. And 5 millimeter extraaxial collection, likely an epidural hematoma from a peripheral middle meningeal injury from the fracture. So call into the clinicians and say, I see a minor injury with a small incomplete fracture, small epidural hematoma measuring 5 millimeters by 2 centimeters by 1 centimeter, and a little bit of subarachnoid hemorrhage. And they respond to you, oh, the patient's doing really well, the patient is doing very poorly and has alteration of consciousness. So the patient will likely get serial scanning, and you're kind of unimpressed with the degree of the pathology, even on the thin section images. At this juncture, if there is a discordance between the neurologic examination and the CT scan, generally the clinicians will repeat the scanning at the 6-hour mark with CT. However, particularly in children where they don't want to do serial CT scanning, they may proceed to get an MRI scan. Let's see what happens to this individual. Okay, so this is the same patient with the 6-hour scan. And as we look at the patient's study, we see that this epidural hematoma has increased in size, and there continues to be subarachnoid hemorrhage. Remember to look contra Coup. So we saw that there was a fracture in the left parietal region and the epidural hematoma. As we look contra Coup, we're not seeing very much in the right hemisphere. And the clinicians say the patient's doing very poorly. So they may scan again at 6 hours, or depending upon the width of this collection, they may intervene. Let's measure it. Epidural hematoma measuring 2.2 centimeters. That's an indication for surgery. As you recall, the epidural hematoma indication was 15 millimeters width, or 30 cc's of volume. In this case, they decide to wait, and the next scan we get is an MRI scan. On the MRI scan, I'm going to show you the FLAIR scan first. So this is a FLAIR scan, dark CSF, dark white matter, higher intensity gray matter, and you can see the collection of blood as well as what looks like an underlying hematoma in the brain or contusion, and likely the subarachnoid hemorrhage. There really isn't much in the way of midline shift. You probably want to look at the T1 weighted scan as well, and it shows the mixed signal intensity blood products. And this is both dark on T1 as well as areas of high signal on T1. And by virtue of the fact that it was dark on T2, we know that this is deoxyhemoglobin. You see that there are some blood products in the subarachnoid space as well. Other than that, not too bad. If we look at the diffusion weighted scans, we just see a little bit of cytotoxic edema in the area of the hematoma. We have a T2 weighted scan as well. Again, dark signal intensity on T2 weighted scan, lentiform shape, likely representing acute epidural hematoma, parenchymal hematoma with edema. Otherwise, looking pretty good. So, you dictate epidural hematoma with mild contusion in the posterior left frontal lobe and parietal lobe with associated subarachnoid hemorrhage, 22 millimeters in thickness, no midline shift. What did you forget to do? Well, I've told you before that the best sequence for detection of blood is susceptibility weighted scan. This is the SWI scan, the susceptibility weighted scan of the exact same patient. You note the very dark signal of the extraaxial collection. However, in addition, look for black dots. Here are black dots of deoxyhemoglobin in the subcortical white matter in the area adjacent to that contusion. But you can see that these little black dots are really all over the place. Here at the gray-white junction, here in the right frontal lobe, these black dots are not veins. How do we know that they're not veins? These are the veins here. The veins usually are branching, and they usually go from smaller to larger as they go centrally. Here's a hemorrhage in the splenium of the corpus callosum. Here is hemorrhage in the subcortical white matter of the parietal lobe, as well as the more posterior parietal lobe. And as we look further inferiorly, look at the frontal lobes. Lots and lots of these black dots all over the place. This is our gyrus rectus region, and there's blood products along the posterior gyrus rectus. Here we have the temporal region on the left side. Look at it, right along the gray-white matter interface, all of these areas of dark dots. These are all areas of shearing injury, hemorrhagic shearing injury from diffuse axonal injury in a rotational acceleration, deceleration injury. There's even hemorrhage in the cerebellum. None of this is apparent on the T2 weighted scan, nor on the FLAIR scan, nor for that matter on the accompanying CT scan from the same day. This is the power of MRI, in particular with susceptibility weighted scanning. In a patient who has discordance between the imaging findings on CT and the neurologic deficits, one should definitely recommend susceptibility weighted MRI scan in the setting of potential diffuse axonal injury.